Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform. Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
So for this podcast, we're going to be doing our first year in review, 2024. So that's going to be best of 2024 : ASCO, because we thought...
You said the punctuation out
loud. Obviously, you told me not to do that, but I thought I'd do it anyway. So we thought we'd start with ASCO. And so, this is going to be our first podcast, year in review 2024. So, Sapna, a couple of icebreakers, if I may. Actually, mate, can I ask you where you are, first of all? That might be quite fun. In as much as you feel free to comment.
I'm in northern Italy at the moment. It's the day before American Thanksgiving, and I came to Europe for a wedding and then to meet my sister.
Yeah, and what are those noises in the background?
You can't hear any noises in the background.
I could.
That is our fireplace. Starting.
Very good. Yeah, well, it's November, right? So it's getting cold. Okay, so proper question now. Icebreaker.
You wanted me to say it was the sound of wood. You wanted me to say it was wood. The sound of wood. I get it. I see where you're
going. So, right, I'm going to ask you, out of office messages, okay? You know, we all do them. Well, most of us do them, not everybody. Everybody does. What are some of the most memorable out of offices that you've seen, or what annoys you about out of office messages and what do you like?
What kind of weird question is this? This is a question you would rather I ask you, I think. I will say Christoph Holler usually has a really cutesy out of office. It usually has like an injured head person or something, and then the phone number for who people are supposed to call if they're that. It has like the office, like a little icon. So he has good use of emojis, I think. You probably don't know this, but when I went to Taylor Swift last year, I had an entire out of office that was just Taylor Swift lyrics. Dear reader, I hope this finds you all too well. I just kept going. At some point I'll find it. Maybe in the fact check, I'll see if I can find it and then read it to you.
No, I do remember that, actually, because we were doing some meeting, weren't we? I think I did. We were doing a meeting, or weren't we? It was like
a webinar.
A webinar, because with a few other people, because I was trying to see if I could get any Taylor Swift kind of quotes into the webinar, and I think I did succeed in the end. But I don't know if you realised at the time that had been my aim. So there's a guy called Ricky Fraser. I don't know if you know him. We've come across him. He's got a podcast actually called Buddies, and his out of offices are always song lyrics, basically, depending on what the theme is. So sometimes, depending on who the artist is. So that's. Hi, Ricky, by the way, if you ever listen to this. So they're pretty funny. I mean, but yeah, you do sometimes get some sort of memorable out of offices, like, I'm so busy that I'm not going to answer your email, but if it's important, email me back when I'm back from my holidays, and then I might do. Have you never had one of those? Seriously?
Well, that's a little bit of that feels like an American style to say, if it's important, email me when you see that I'm back in office, to put it back at the top of my inbox. That just sort of implies you're not really going to spend your out of office time sifting through. And if somebody can figure out their problem or issue, sort it through. But if you can't, put it back at the top.
Yeah.
So note to self, you don't like that.
Not really.
Don't like the put the burden on the sender to resend an email. Got it. Don't like that.
Yeah, and I've got a league table, as you know, where I store memorable out of office responses, for future posterity, basically.
Okay, so in the fact check, you're going to read some of those then.
Yeah, that's actually not a bad
Should
idea,
do.
is it? All right,
Okay.
listen. So
But back to this,
to
Ricky.
work. Go on.
Hold on.
Ricky Fraser.
Back to this, Ricky Fraser. Yeah, back to this. Do the lyrics actually make sense? Is it like, "Welcome to the Hotel California. What a lovely place,"
Yeah.
or is it?
Yeah.
Okay, so it like really makes
No.
sense in context of what it.
Yeah. Yeah.
Okay.
He spends a lot of time on this, and they're thematically coherent as well. So, I mean, it's actually very impressive. They're quite big. That's the only thing. The out of office message is just like half a screen.
Okay, we know you're a sizist. Come on now. Again with
I apologize.
gestures.
Yeah, I apologize. Okay, so we thought there were kind of 4 things, I guess, that we wanted to cover in ASCO 2024. First and foremost, NADINA. Yeah. So at ASCO. So yeah, why don't you chat a bit about NADINA?
Yeah. So NADINA, as Jeff Weber told us, was the world's worst kept secret. That it was a plenary at ASCO 2024, but long awaited. We were so excited to see this one get accepted and presented by Christian Blank and colleagues. So NADINA stands for the neoadjuvant nivolumab plus ipilimumab versus adjuvant nivolumab in macroscopic resectable stage 3 melanoma. Phase 3 trial, randomizing patients with resectable stage 3 disease, clinically assessed with positive lymph node disease. They could have also had in transits, but they needed to have positivity for lymph nodes, and then naive to essentially all systemic treatments. They were randomized to therapeutic lymph node dissection followed by adjuvant Nivo, which would be the standard of care. The experimental arm was 2 doses of what we, of course, call the flip dose Ipi-Nivo. So 2 courses of that, and then therapeutic lymph node dissection. And they, just for clarification's sake, in the NADINA trial, those 2 cycles, you typically didn't go to surgery sooner than the full end of cycle 2. So if you start counting at week 0, 0, 1, 2 is the first cycle, and then 3, 4, 5, let's say, I'm doing that those maths for that reason, then surgery would be week 6 or later, right? And in SWOG, sometimes people will say, well, you gave 3 cycles, and so surgery didn't happen until week 9. That's actually not the case. If you count the SWOG S1801 study, it was 3 cycles of every 3-week pembro. So 0, 1, 2 was cycle 1, 3, 4, 5 was cycle 2, and then 6 was the start of cycle 3, but on average, the median time to surgery was at week 7. So these studies really line up in where they took patients to surgery. That was really just a point to say, when you give single agent therapy, surgeons often don't hesitate about a cooling off period because they feel like single agent anti-PD-1 doesn't have as tremendous an inflammatory mark, say, in their surgical site. But with Ipi-Nivo, there might be, so they like to cool them off, typically a minimum of that full cycle. Okay. So the experimental arm was 2 cycles, followed by a therapeutic lymph node dissection, and then a personalized adjuvant approach. So if you had a major pathologic response, which is less than or equal to 10% of viable tumor cells, in the tumor bed that the pathologist can identify, was ideally the total tumor bed. If there's less than 10% viable tumor cells, then that's considered a major pathologic response, and those patients were completely finished. And the implications being that these high risk patients who typically have been dispositioned for a long course of treatment are now, with the NADINA regimen, potentially finished at week 6 or shortly thereafter. If you had anything less than a major pathologic response, so a partial response or a non-response, so anything more than 10% viable tumor cells, then you did need to take some adjuvant therapy. And if you had a BRAF mutation, it was a kind of a mandatory move onto targeted therapy. And if you were BRAF wild type, then the patients got adjuvant PD-1 for a year. And so the study enrolled 423 patients, ultimately randomized. 485 walked in the door of the study. 62 did not meet eligibility criteria. And so 423 were randomized. It was a 1-to-1 randomization. And then they give numbers on who didn't go to surgery. So it's always important in neoadjuvant trials to make sure your do not go to surgery rate is not terribly high due to toxicity or progression, so that you're not taking these curative patients and missing their curative window. So in the standard of care group, 3 did not go to surgery, 1 because of disease progression, 1 because of withdrawal of consent, and 1 they deemed was ineligible after randomization. So remember, on the standard of care, you basically go straight to surgery, but still there's just enough time that, you might have a little tiny disease progression. And then 38 did not start adjuvant therapy. And that's, again, because postoperatively you can have these recurrences. And so indeed, 29 had recurrence, 3 did not want adjuvant therapy, and 6, it says we're on treatment at cutoff. So I don't have clarification on if that means they were just like kind of newly enrolled and maybe just in the surgical part and just hadn't started adjuvant therapy yet. On the neoadjuvant arm, 14 did not undergo surgery, so 14 out of 212. And here it was 3 for toxicity, 5 had progression. 5 had surgery after sort of their cutoff window, and then they said 1 was unknown. So just important to look at those numbers there. Importantly, I think everybody was really wanting to know how many patients got that major path response, so they didn't have to take adjuvant therapy. And it ended up being a high portion of the study. Like 60% of patients had a major path response. So they were finished with 6 weeks of therapy. That was incredible. And really the highlight slide is their event-free survival curve. It does have short follow-up at the time they presented it at ASCO, which was a median of 9.9 months of follow-up. But they had a striking difference, of course, between the neoadjuvant arm and the adjuvant in terms of EFS, 83.7 versus 57.2 at the 12-month landmark time point. And the hazard ratio there is 0.32, very tight confidence interval, highly statistically significant. I mean, just really such a well-done study. So this was, if you are in the melanoma space or you're in kind of in the neoadjuvant space, this was really a highlight for so many of us. Great to see this work. And it had a simultaneous publication in NEJM, of course. So congratulations to Christian, Georgina, Minky, the whole NADINA crew, Richard, Alex, all of them. It's so well done. So that was our number 1 for Best of ASCO.
Yeah.
Go on.
I was going to say, fully agree. Fantastic to see it. Great to see melanoma in the plenary session as well. And just for the record, I don't know if we said it or not, but we discussed this more in episodes 26 and 27. So 26, I think, with Christian Blank, and 27, where you and I go into things in a little bit more detail. I'm just going to say a couple of other things, actually. No, go on, you first.
Oh, I was just going to say you're right. I forgot to do the callback, and that would be great for listeners. If you wanted to go back into our archives and listen to 26 and 27, you'll just get a little bit like longer, deeper context and conversation around NADINA.
Yeah, so absolutely. And so the other things I was going to say, is great to hear you anglicising the word maths, which you did. I don't know if you noticed that when you're going past. You said you did the maths. Yeah, you anglicised it. So probably need to keep an eye on that. And then I'm going to ask you an impossible question. So when do you think we might see some OS data from NADINA? In as much as you feel able to say, and that's part 1. Part 2, will it be positive for OS or not, do you think, Sapna? Again, in as much as neither of us are privy to anything that's not in the public domain. This is opinion, right?
Yeah, I mean, I didn't have the study. I don't know, but I would think the OS, we typically don't really look before 3 years. I mean, that's really, even in our metastatic trials, that's where we kind of are estimating our OS to be. So, it'll probably be another 1.5 years, I think, before we see the first signal of OS. I think there's every reason to believe it's going to be positive for OS. I mean, just the way the curves are separating, I think there's every reason to have hope. And, it would be incredible to know that we are curing more patients, ideally those that, survival turns into cure, so that we are curing more patients, doing less surgery, and ultimately they're spending less of their time on treatment. Would be fantastic.
Yeah. I mean, I think that's going to be an incredibly important result, which we're going to be looking out for. I think it'll probably be positive for OS as well, I have to say. I didn't press you for, your level of certainty, but I guess we're on the same page there. Right. So I'm going to do 10-year follow-up for COMBI-AD now, which Georgina Long presented. And it's going to be a bit
and our
quicker.
Listeners know how much you love a long-term follow-up. James
absolutely.
Larkin et al. Loves a 3-year and a 7-year, and come on, you love a good long-term follow-up study.
Yeah, I think you missed 4-year there and 5-year.
I knew. I left the gaps for you to fill in there. I know you know where all the publications are.
7.5 and 10. In any case, so anyway, so 10 years follow-up from COMBI-AD, which Georgina presented, and the publication's now out as well, I think relatively recently, in NEJM. Episode 29 is the episode where you and I discuss this in more detail. And I mean, for me, it sort of confirms what we knew already, to your point, to some extent, Sapna, about, further data cuts. But I think 10 years is important. No new safety signals. I guess the thing people are talking about is the OS. And to cut to the chase, it was 0.8 overall, with confidence intervals just overlapping 1, p-value 0.063. So I think that's something to say. And I guess the other thing I might just sort of pull out here is the whole business about V600E versus K, because I think there's been quite a lot of discussion about this. And I'm actually looking at the slide now, the forest plot, and this is OS in the ITT, V600E versus K. And so if you do that, obviously most of the patients had V600E, and the hazard ratio there is 0.75, so better than the overall OS. And that confidence interval does not overlap 1. Then if you look at K, it's not a massive number of patients, right? It's like 80 patients in the whole trial. So the confidence intervals are broad, but the hazard ratio there for OS is pretty close to 2. 1.95. So in the presentation, and actually in the manuscript, and I think in the discussions that we're all having amongst ourselves about this, there's been some comments on that. And I think what we said when we did the podcast, or maybe what I said, can't exactly remember, is that this is OS. But actually, if you look at the DFS for E versus K, I don't think they were that different, suggesting, at least in terms of relapse-free survival, dabrafenib and trametinib doesn't seem to distinguish, if you like, or differentiate too much between the two. But then, of course, OS also represents what happens after the patient's relapse. And so what I'm wondering here is whether there's some differences there that we don't understand very well. And, of course, this is all speculation after relapse in E versus K. But go on.
I think we said this on that episode 29, where I asked the question, what do we know about V600K responsiveness to immunotherapy? Because presumably at recurrence, right, people might get BRAF/MEK inhibitor again, but you might obviously reach for the other class of drugs you haven't used. And we weren't sure we actually knew of any data sets out there other than this COMBI-AD that might suggest, again, we'd have to parse through a little bit more granularly. If at relapse it was immunotherapy, are they doing less well because they've relapsed, or are they doing less well because they do less well with immunotherapy? It's kind of like a nuanced layer in there. I don't think we know. So
no, I don't think we do. It's pretty interesting.
Another point that we had made that I think is important when interpreting this COMBI-AD, adjuvant therapy for BRAF positive melanoma improves RFS. That's the same bar that we have for adjuvant immunotherapy. It's just shy of improving OS in intention to treat, but obviously looks positive in an exploratory fashion for E. And the point that we had sort of made for people designing clinical trials is that this represents 9% of that total study population. And that 9% can swing this principal analysis, this primary endpoint. And just that 9% can really move it. And to your point, the forest plot's way on the other side. So it's a big swing that changed it. If they're just subtly apart, maybe it won't make that much of a dent in it, but that's important. And we have to remember that the FDA told us during the listening series that we can have subsets of patients in these large phase 3s that don't count towards intention to treat, but they have to be pre-specified in CARD. If you think, you wanted to study uveal or mucosal or something like this, you can do it, but you have to be very careful. Don't include that in your ITT. Make sure you pre-specify, carve it out. You can have a separate analysis just for them so that you don't have to have a separate study, a separate protocol, et cetera. Not that we would have thought you needed a separate protocol for B600K, but that's that.
Yeah.
Okay.
All good points. Yeah. So then next one we're going to talk about was the 3-year update from the KEYNOTE 942. So this is what's called the Individualized Neoantigen therapy. So it's a mRNA vaccine V940 plus Pembro in the adjuvant setting versus Pembro alone. So this links to our discussion actually with Jeff Weber and, personal reflection. It was wonderful to have the opportunity to talk to Jeff after ASCO, and he presented these data, but we talked about some other data sets. So that was, that was very memorable for me anyway, talking to Jeff. I'm sure it's the same for you. So that's one thing. I think in terms of the data, though, really we're seeing confirmation of what we'd seen before in terms of RFS, DMFS, and actually a slide as well early. And the title of the slide is encouraging trend for OS, but really very few events in terms of overall survival, meaning deaths. And actually the total number in both arms was 9. I think very difficult to interpret that. There was a hazard ratio applied to that, but I think, that obviously requires caution in terms of interpretation. So I'm not sure there's too much else to say about that, actually. Did I miss anything out?
No, I mean, we first heard this 942 at AACR 2023. That was the first year we heard the report of it. Jeff presented it there, actually. He called this randomized phase 2 one of his favorite trial designs. This was a 2-to-1 trial design. So I think we have to remember it was 150 patients randomized 2-to-1. The vaccine doesn't come in until 6 weeks or so. And so that's why you see, if you look at the RFS curve, some of the conversation around that is you really don't see a separation until late in that first year. And potentially that's because the vaccine doesn't start until 6 weeks. So it's going to take time for that individual neoantigen therapy to actually be able to generate a T cell response. And therefore, the curves are not going to separate right away as they would maybe say on NADINA or something like that. And then where there was a concern that perhaps these curves may not sustain separation over time at this 3-year mark, not only are they sustaining a separation, but the absolute difference between these two study arms might even be getting a little bit bigger for RFS and DMFS. So now at 30 months, almost a 19-point difference in RFS and a 20.6% difference in DMFS. So it looks like it's holding up. So pretty good.
Yeah. Yeah, and at the time of writing, I guess it's fair to say that the phase 3 trial, I think, is now recruited. So that's going to be a hotly anticipated result in due course. Okay, so then the last thing that we're going to talk about, Relativity 48, which links to episode 28, where we talked about that in a bit more detail. But before you talk about that, I'm just going to say that the one thing that impressed me most about that was the trajectory of the PFS curves, because just to make the point again, say with Checkmate 67, even the Ipi-Nivo arm, you have this quite steep drop off really on the first scan where people are progressing. And my impression, and it's speculation, is that it sort of looks a little bit like you weren't getting that drop off there, but over to you.
On the Relativity 048?
Yeah.
Yeah.
Totally impressionistic.
That's an interest. Yeah, no, I like that though. We like good impressions. So Relativity 048 is a study that people probably maybe heard about. Certainly our European colleagues know about it because they ran it. This was triplet checkpoint blockade. So Nivo, Rela, Ipi, with the Ipi given at a dose of 1 milligram every 8 weeks. And that triplet checkpoint blockade was for essentially untreated advanced or metastatic melanoma. So checkpoint naive, they could have been exposed to neoadjuvant or adjuvant therapy as long as it had been more than 6 months. So, but checkpoint naive in the metastatic setting. So, this study was 46 patients, open label, single arm. We waited 4 years for this data. I think that's why I'm only just putting such a fine point on it, because these 46 patients were giving us everything at 4 years. Basically, we're waiting for all of this. The objective response rate here is 58% for triplet checkpoint blockade. Of course, you are the guru of the first doublet that we used in checkpoint. It's marginally better than doublet. Of course, all the Rela programs, Nivo Rela and then Nivo Rela plus anything else, they use, typically they use blinded independent central review. This study used investigator review. So, it could be that this is just a little bit higher number because it's investigator review. If it was blinded independent, that number could come down. It's hard to say for sure. But right now the confirmed responses with doublet checkpoint blockade is in the high 40s, 44 to say 40. I think it ends up in that mid 40s, maybe is what I should say instead of high 40s for confirmed. Now we know that obviously the published results were out there and they were unconfirmed. Nevertheless, these investigator responses is 58%. Maybe we would have liked to have seen more CRs with triplet, because maybe we would like to think getting to a CR, as we've talked about with Mike Atkins, Tony Rebus, and just ourselves in due course, getting a CR seems to be a very useful thing if you believe the radiology is your strongest tool to tell you that. We know there are other tools to be used, but if you can get to a radiographic CR, we know you're often in quite good shape, though relapses can occur. So we didn't see even more CRs here, which is curious. Maybe it's still in the 17% range. So you're not necessarily getting more cures with that little bit of IPI added. But as you mentioned, the PFS is quite striking. Not only the numerical PFS that's not yet reached the median at 4 years of follow-up, but also the shape of this PFS curve. It's not a massive steep drop down below 50% with the plateau. It's a drop, no doubt it's a drop at that first rescanning time point, in the first 3 to 6 months, that's understood. But it's a gradual drop. It's not that massive stair step. It's more of a kind of a triangular slope, if you will. So a PFS of 40, not yet reached at 48 months, is really striking. But with the massive grain of salt, it was 46 patients. If you're running the study and there's only a few slots at your site, you have to admit the psychology behind what patient you put on this study is going to be a heavily curated patient, because you only have so many slots. You want the drug and the patient to have the best shot at showing a signal of efficacy. So you're not, there probably is some curation of the patients that went on this trial. Having said all of that, I don't know even a favorable patient population that could have this kind of PFS with the tools that we have right now. So very excited to see this. I think triplet is now being investigated in other potential landscapes, first line and second line. I think the biggest thing people would worry about is toxicity. So when you're giving triplet and even IPI at that low dose and reduced frequency, what is the toxicity? Well, any SAE, 100% of patients got any SAE. So that's in line with our other doublets, which are in the high 90s. And then grade 3-4, it's 59%. Any AE. If you look at discontinuation due to grade 3-4, it's 22%. So it ends up higher than Nivo-Rela, lower than Ipi-Nivo. And maybe that's where this 1 milligram dose of Ipi every 8 weeks actually does with this regimen, right? The toxicity is somewhere in between. You don't see myocarditis jumping out here. You don't see adrenal insufficiency. small study though. I think in, a larger data set, obviously we know those toxicities are ones that we pay attention to with RELA, so those things can emerge. So that's that. That was our kind of top 4, we thought, from ASCO of this year. In our year in review, those studies are still ones we think about and talk about 6 months later. Right?
Fantastic. Yeah, no, I was loving the hand gestures there as well. That was really expressive. Just with, that, yeah, there's shapes of those curves. Yeah. Are you taking a leaf taking a leaf out of my book?
Well, not it depends how big the book is, I guess. We do know I'm going on very little sleep. This is like not even 30 minutes of proper rest. So good. Okay. So is that it for Best of ASCO?
I think so.
Okay. All right. Thanks.
Hi, everybody. I just wanted to do a quick fact check on our Best of 2024 ASCO episode. I had mentioned there about the FDA listening series and how they had mentioned, in the large phase 3s, you can have these small subsets of patients with maybe the rarer subtypes to be tested. I just wanted to verify. So I went back to the FDA listening series, and they don't actually specify that they won't count those populations against you or that you can do that. It was discussed at that listening series in January 2020, the one for ocular melanoma in particular, but it's not showing up in the transcript. So I didn't want to mislead anybody. The idea is that when we do these big phase 3 trials, often these rare subsets are not eligible, but it would be a nice movement to start to see large randomized registrational phase 3s taking the rare subsets as a small expanded access cohort, if you will. So those slots would be offering access to patients who aren't eligible for whatever reason, rare subtype or poor organ function, whatever. But because they're in the expanded access part of that registrational phase 3, they wouldn't count towards the intention to treat. It would be nice to see that directive from the FDA more clearly so that companies can start designing trials that way. Anyway, just wanted to update that with that fact check. All right, everybody. Happy New Year.